Hello, everyone. My name is Kaitlin, and this is Jacob on the other side. This is our DAP project. Um, so, for our research question, we chose for adults with psychotic depression by using a combination of cognitive behavioral therapy with pharmacological management and comparing it to only using cognitive behavior therapy, which of the options would show more of decreased symptoms, improved thought process, and treatment adherence over the next 6 to 8 weeks. The significance of this was to explore whether cognitive behavior therapy and medication is more effective than just CBT alone in adults experiencing psychotic depression. So, for the dynamics of the disorder, psychotic depression affects the nervous system through the dysregulation of monoamines, including serotonin, norepinephrine, and dopamine, and an increased amount of activity of the hypothalamic pituitary adrenal axis. Psychotic features can show more cortical subcortical dysfunction, like impaired perception and cognitive control. And then antidepressants and antipsychotics are recommended since psychotic symptoms often decrease good judgment and increase risks. And then just for the patient introduction, Mr. C is a 29-year-old male. He was admitted to a psychiatric ICU for major depressive disorder with psychotic features. A patient did not disclose any religious affiliation, reports single, no children. Patient identifies as male. He lives in an apartment by himself, currently on a 24-hour supervision following SI and auditory hallucinations. So for the MSC pertinent findings, the patient was admitted to the psychiatric ICU following suicidal ideation and auditory hallucinations. The reports show that the patient reported feeling empty and hopeless. The patient's affect is blunted and congruent with displayed emotions. Patient's thought flow seemed to be slowed. He talked about feeling guilty and worthless. The patient's auditory hallucinations were described as someone with a very deep voice, so probably a male, telling him he is a failure and always is screaming loudly. The patient denies visual hallucinations currently, is oriented to person, place, time, and memory. Memory is intact. The patient recognizes his own thinking is off when feeling depressed. Judgment is affected due to the influence of hallucination, but he is currently following safety protocols. And then, in regards to the SI, patient reports currently no intent. So, with all of this together, all the factors place the patient at moderate risk for self harm. And then these were the medications that Mr. C was on. So the first one was sertraline, so Zoloft. This one improves depressive symptoms, SI, hopelessness, and low motivation. Patient is also on risperidone. This one is to target the hallucinations and psychotic distortion, improving thought clarity. Patient is also on lorazepam as needed. This one helps the patient stay calm, reduce agitation, sleep better, and overall have a sense of have the patient have a sense of safety. And then the last one, as PRN as well, haloperidol is a rapid acting medication used only if psychosis or agitation were to escalate suddenly.
Okay, so here are the three priority nursing diagnoses for our patient, Mr. C. The first risk is risk of self harm, which is the most critical and important one, which is why it's listed first. He was admitted for suicidal ideation and continues to experience auditory hallucinations. Research shows individuals with major depression, especially with the psychotic features, have heightened suicide risk. So this directly connects with like our picket question because reducing these symptoms and improving treatment adherence is really important. It's essential for kind of keeping him safe in general. Our second diagnosis is the disturbed thought process. So psychotic depression impacts the perception and cognition. Sorry. And Mr. C's feelings of emptiness and hopelessness, along with hallucinations, kind of show like clear disruptions in his thinking, and everything's not very clear. These symptoms affect his ability to engage in treatment and his overall decision making and judgment. Our third diagnosis that we found is ineffective coping. So, Mr. C lives alone and obviously has some limited support from that, and has his history of suicidal ideation, all of which point to maladaptive coping. Evidence shows that combining CBT with medication improves coping skills, functioning, and reduces relapse, making this a very key and good area to address everything for him. Next slide. For nursing interventions, we have 5 listed here. So we focused on strategies that directly support safety, symptom management, and treatment engagement. First, frequent safety monitoring is essential due to Mr. C's suicidal risk. We also want to use behavioral interventions and education to support medication adherence. Both have shown to improve stability across a lot of patients in studies. Motivational or therapeutic interviewing helps build trust and encourage participation in treatment for patients. And then finally, ongoing progress monitoring and evaluating just helps ensure that we track symptom changes and adjust the care plan as needed in case there is any sudden or changes that need to be addressed. So for evaluation, we outlined that improvements we would expect if the combined CBT and pharmacologic approach were implemented. So we would aim for at least 7 days without suicidal ideation, so 1 week, a 50% reduction in hallucinations within 6 to 8 weeks, because as we know, psych meds do take a fair amount of time to have effect. An 80% CBT attendance, and 90% medication adherence. If interventions were not implemented, then the goal would just be gradual improvement in his mood stability, clearer thinking, and just helping him with better coping mechanisms. These changes would be evaluated through Mr. C's self-reports, observations through staff, and symptom tracking over 6 to 8 weeks, which is just consistent with what studies support for monitoring patients with psychotic depression. So, in conclusion, to wrap up all this, the combined approach of using CBT with pharmacotherapy shows to be the most effective and promising option for patients like Mr. C who are experiencing psychotic depression. The studies and research shows that using both of them together can help reduce distress, improve coping with hallucinations, and lower relapse rates, which is a huge part of this. While CBT alone is often more effective for depression than than psychotic disorders, the evidence supports that pairing it with medication provides stronger and more comprehensive outcomes. So overall, the combined method works best with Mr. C's clinical need and focuses on our Pickett question. And here are the references we have and studies we referenced in this project. Thank you very much.